everybody, and welcome to the Overrun on YouTube. I am here with Dr. Peter Antevy from Florida, the jack of all trades. If you're not watching his NAEMSP and Florida segments on YouTube, you should. It's some of the best free medical education available. When do you air that? The NAEMSP, is that weekly or is that monthly?
Yeah, it's every week, Friday, 11 a.m. Eastern Standard Time.
It's terrific material, you guys. If you're not watching it, you should. The interview that we have this month with Mike Birkenbush was a direct result of Dr. Antevy having him on the show. So thank you for joining us. We're going to talk about Pediatric Airways today. Dr. Antevy, one of the first things that I think EMTs and medics are exposed to is the anatomical differences in adults and pediatric airways. Take a couple minutes to talk about the important differences, what EMS providers should know, and certain little like pearls if you're going into a call for, say, a pediatric respiratory. What do you want to kind of have in mind and look for?
Awesome, man. Well, first of all, thanks for having me. It was great to be with you. Yeah, pediatric airway is important. It's kind of a basic skill that people just really need to understand what the pediatric airway looks like, how it's different. I always recommend that you just start with your eyes, right? You could do a lot from a distance with these kids. For many years in the emergency department, I would see students come in with me, and they would just like go like right up to the kid, and the kid all of a sudden would start getting angry and upset, and you lose the entire examination. And sometimes taking a thoughtful approach, obviously if it's cardiac arrest, but at the poolside, we're not standing back to look that the kid is not having any
Right. Yes.
respirations, right?
When they're really sick, do something. Let's start with
Right,
that.
right. So we're talking now about the kid who is an asthmatic, he's got croup, got bronchiolitis, maybe a pneumonia, it could be a sickle cell patient, it could be a number of things, but you could just look at them and I start from the face, you go down into the neck, over the clavicle area, and then down into the chest. Now, if they're wearing a shirt, it's hard to see, but a lot of time if it's an infant, they're in a onesie, and you could actually see the work of breathing. So that work of breathing is very important. Why? Because kids will tire out quickly, and if kids have a harder time oxygenating and ventilating, so if they're in trouble, they'll go hypoxic quicker than the adult, and they become hypercarbic quicker than the adult. So having the ability to know what your patient is doing, how long they've been doing it for, what is there, any prior illness, you're kind of getting a story from the mom and the dad as you're just looking at this kid without going up and just saying, "Hey kid, let me examine you." And obviously, once they get to a certain age, it's fine because most, let's say, 6 years and above, let's say, they don't care. They're used to people examining them at the doctor, etc. But if once you get into that toddler age, you can kind of lose the exam right away. So I guess I would start by visual diagnosis, understanding what you're looking for. Nasal flaring, right? That's number one. Are you seeing the nares flare out, meaning that they're actually that's part of the work of breathing that they're doing. You look at their mouth. Are they breathing with their mouth open? A lot of kids who will come in and they'll have some sort of infection that's, at the tonsillar area, whether it be a retropharyngeal abscess, just a tonsillar infection, a peritonsillar abscess, and you want to listen for those kids. Are they making a weird sound when they're talking, when they're coughing? So all those items you're just looking for, and you can kind of tell up here. Are they drooling? Huge thing in the airway, because you will find children who have some sort of upper airway obstruction. And even maybe we have had kids that have a foreign body in their esophagus that sounds like it's an airway obstruction, but it's not. And those kids will just continue to drool and drool because the esophagus is being blocked. They cannot swallow any of their secretions. And over time, if you end up there an hour later, 2 hours, 3 hours later, that inflammation is now pushing in the trachea. And now you're hearing airway noises. But the key was to look for the fact that the kid can't swallow because the esophagus is blocked and they're drooling. Batteries are another big one that people miss in EMS all the time. There was a big lawsuit here. Thank God it wasn't one of my agencies. But mom said the kid swallowed something. Kid looks perfectly fine because the battery's sitting there only for the last 15, 20 minutes. Mom has no idea it's a battery. They disregard the mom. They leave and they come back 4 hours later. And then the kid ended up needing to get his entire esophagus clipped out. The kid will never eat again from his from his mouth. Everything is now a G tube.
And that's, again, it's part of the assessment asking, like, have they eaten anything? Have they put anything into their airway? And one of the things with kids, especially, you mentioned under 6, and any parent will certainly know that kids really like to put things in their mouth. It's
Yes.
the origin of the Lifesavers candy and Cheerios and all that is all, so there's still a little bit of an airway if the kid puts it in their mouth and inhales it. So
Correct.
what is it about the pediatric airway compared to the adult airway that makes it more prone to being occluded when a kid tries to just put something in their mouth? Because adults choke, daily. But I think we have a little bit more control over our airways. But what is it specifically about the airway anatomy that makes kids more prone to choking?
Well, I think first of all, kids who are younger and the parents, let's say, for example, give them a grape, right? Which is a classic thing where these younger kids aren't fully chewing, right? So if you look at how many teeth children have as they get older, obviously when they have the full complement of their teeth, then that's less of a problem. But you have kids, obviously from infancy, that have no teeth. The first teeth that are coming in at 6 months of age, the bottom two or the upper two usually come in first. So if you're giving them things of substance, they have no way of chewing that down. So obviously in early life, all that food is soft food. Obviously it's formula or breast milk early on, and then you start incorporating. That's number one. When you look at the anatomy of the child, they have a huge tongue compared to the rest of their mouth, right? There's not a lot of room in there. When you go back and you actually see the anatomy of the child's head, right? So if you have a kid who's just leaning back, they do that because the occiput is so big, and now they're actually closing off their airway that way. Their airway is more anterior. So when you actually have a child laying back and let's say you're going to intubate that child, and you have your VL or your DL in there, people don't realize that you kind of have to look up around the corner, and that's where the airway is going. So their anatomy is different as they grow and elongate, and the airway is not that anterior. But I think early on, it's just the foods that they're given, the fact that they don't have teeth, a larger tongue, and um, the airway is really tiny, right? So think about it. If you have, we've had a couple kids in the last couple of years who've had issues with peanut butter, and once that peanut butter gets into that airway, it's very difficult, if not impossible, to get it out. And what you end
Yeah,
up
I'd
having to
imagine.
do, yeah, I mean, what you end up having to do is you end up having to intubate them and then trying to push that object down right main stem and then pull it back out. So at least you have the left side of the lung. That's not a situation you want to be in. But think about it. And I mean, how else would you get peanut butter out of a kid's airway? It's sticky,
Yeah,
gooey, sitting
yeah,
there.
no suction is even a decanto catheter is not going to be able to suction that out. And sorry, Jim, but
It probably has the
and with
best chance of, but
yeah,
right.
if you're going to do it. But it's also with something like with a kid, because you can also have the compounding factor of a peanut allergy on top of the aspiration,
Yes.
which that's a whole. I'm sure we could do an hour on that nightmare scenario
Yes.
that someone came up with on one board exam at some point. But
Right.
so when assessing your kid, you mentioned the occiput of the head. So if I'm an EMT and I don't have advanced tools available to me, I don't have McGill forceps, I don't have intubation supplies, what are some of the best tools that I can use at the basic life support level to try and adjust this child's airway? Because we know that most pediatric cardiac arrests are caused by respiratory arrest. So if we can solve the respiratory problem at a BLS level, we might be able to save the cardiac arrest.
So first, I'll start with the non-arrest patient. I'll start with that kid who, let's use croup as an example, right? So with croup, they have upper airway inflammation, and um, you know, a lot of people don't recognize that when that kid is actually sitting there, and if they're getting worse and they're tripoding, they're really trying to open that airway by holding it forward. A lot of people come in on the BLS level and they'll say, "Oh, we have to lay that kid down. Pull that kid from mom where the kid was comfortable, was
Stress them out,
struggling,
make them cry
right?
more.
Boom, you lay them down, and now all hell breaks loose because now they're screaming and crying. The airways are becoming even smaller. They're not able to just mechanically get that airway open because now everything's pushed back. The tongue, the epiglottis is flopping backwards, and your kid's epiglottis is a lot larger.
Right.
And so instead of leaning forward and helping open it, you've now made it worse. So I think the classic example I see a lot of people make is that they want to remove child from mom and dad. So rule number one is that unless a kid's in cardiac arrest, there's no need for you to do that. At least sit there and make an assessment, look at the kid, and if you see the kid is struggling and leaning forward, it should automatically tell you that you shouldn't be laying that kid down unless you really, really have to. So what do? You're talking to the mom, you're looking at the kid, you're evaluating, you're asking questions. So for example, people have different problem differentiating between asthma and croup, right? So when I teach the class that I teach, I tell people asthma is a child who's been coughing all day long. The kid's been coughing and coughing and coughing, and finally nighttime comes along, and the parents they're not sleeping, and they're giving albuterol treatments. That's the story that you'll hear. Asthma doesn't come on severe all at once unless it's some sort of reaction.
Right. It builds over time.
Right. It definitely builds over time. Usually the kids who are getting really sick with asthma have been really sick with asthma before. So the parents have the nebulizer out. They're kind of old pros. They've been saying, listen, I've been getting treatments.
Not their first rodeo.
Not my first rodeo. So you could walk into the house and you could see all the paraphernalia. You know what's going on. You ask them any history of going to the emergency department, needing steroids. Are they on a rescue inhaler? Are they on a controller inhaler? Have they been to the ICU? You get all that within 30 seconds. Then you say, okay, this is an asthmatic who's been to the ICU 3 times, has been intubated twice. That's the kind of kid that I better get moving and, start to get some things going in the albuterol and maybe getting line some fluids and some steroid if you carry it. The kid who has croup was fine all day, maybe a little sniffle. Mom put the kid down at 8 o'clock. They went to go to the couch and watch TV. And for a few hours, everything is fine. But what happens in croup is that when you fall asleep, if you have kids, you know this. I've been putting my kids to sleep for a long time, and my 11-year-old finally, I don't put him to sleep anymore. But there's that moment where his breathing pattern changes to I'm asleep pattern. We all know it. And that sleep pattern is in autopilot mode. It's not as deep. It's a lot lighter. And so you're not getting a big tidal volume. So when you have croup and your airway is more narrow, now you're getting that shallow respiration, and that end tidal went from 35 to 40 to 45 to 50 to 55, and now it's midnight, and the kid's PaCO2 is about 60, and the brain says alarm. All right, the kid gets up, has that barking cough. Because of the high end tidal CO2, the kid looks discombobulated. Mom comes running in, doesn't recognize her child, looks like an alien. Big barking cough, and now the kid is having this big problem. If you don't ask those questions when you get to the house and say, when did this happen? Did you put little Johnny to bed and woke up suddenly? Now all of a sudden you have a kid, hey, this is croup. Let that kid sit on the mom. The only thing I'm going to do if I hear a stridor at rest, that means the kid's not crying because I'm standing 10 feet away.
Right.
And I don't have my whole crew. If I have an ambulance crew of 2 or 3, or sometimes we have 7, if you bring all those people into the room, you're done, right? Keep the kid on the mom. Look at the kid. If there's no stridor at rest, you're good. If the stridor at rest, in our protocols, it's epi-ned. Epi 1 to 1,000, take 3 to 5 ml, drop it in there, no dilution, boom, you're done. Now, if the situation continues to get worse and now you're at the point where you're respiratory failure, right? Respiratory failure means the kid cannot oxygenate or cannot ventilate well enough. And you know that If you let the kid continue along this path, well, they're going to go into respiratory arrest, followed by cardiac arrest. So now you need to figure out, is this kid having an oxygenation problem or a ventilation problem? Well, that shouldn't be too hard to do. Look at the skin. Do you see that this kid is having like a bluish hue around the lips, right? Just look at the skin color. Ultimately, you put a pulse ox on. That's a BLS maneuver, right? Oh, look, the sats are 70%, and the kid is 6 months
It's too
old.
low. Still a C,
Right.
but it's too low.
Right. And this kid is, let's say, an ex-preemie. Now this kid's 6 months old, and now it's the middle of the winter, so this kind of looks like bronchiolitis, and this kid is just not oxygenating well. All right, well, let's give the kid some oxygen. That seems like a fairly simple thing to do. Just go with a non-rebreather. Boom. Okay. Does this kid's O2 come up? Great. How do you test out the other side? You put waveform capnography on. We should all have that. That's your part two of the respiratory cycle, right?
Right.
Now, if the kid is not even conscious because they're in such respiratory failure that their end-tidal CO2 is now has skyrocketed, they're not even with you really much. Well, that's a kid that you really need to provide positive pressure ventilation. And at the same time, you can have your SpO2, your end-tidal CO2. So we're talking about the very basics of a pediatric airway. And if the kid is to the point where you're now, bagging the child, and the child is needing just that basic BVM airway, well, go get an airway adjunct. I know you've probably seen this a lot, Ed, but we see a lot that people don't use the OPA, they don't use the NPA, and those are wonderful adjuncts.
Do you think that's more of an ignorance function, or is that more of a function of fear with kids?
Yeah, fear. I think it's fear. I think the perfect patient to try this on are the kids who are seizing, right? All those kids need an OPA, every single one of them. Why? Because if you're having a seizure, you're obviously having very erratic movements. You're not having these normal respirations at all. Your mouth may be shut. You may be kind of trying to clamp down. The tongue is now in the back. It's impeding air movement, airflow. Go in the OPA so the first thing to do in a seizure is not to grab the versed. The first maneuver in a seizure is these two hands, right? So we talked about it earlier. Kid has a big occiput. And people always say a shoulder roll. I like it almost like your towels are stacked in your closet, like in a square. That's what I put under the kid's shoulder. So now the head is not leaning forward like that.
You almost want to make it like a little bed, kind of, where like instead of a pillow, they're just they're laying flat, but their head is on the bottom side.
It's exactly right. Exactly. But I see a lot of people trying to roll it up like a roll per se. You don't want to do it. You're basically trying to elevate the entire body so that the head is not crushing the airway forward, number one. And then it's your basic airway maneuvers with your hands, right? So head tilt, chin lift, jaw thrust, and the child's having a seizure, OPA, oxygen, okay? If you have a BVM and you think you need the BVM, then use the BVM. That's step number one. Step number two is, okay, let's get some versed. Intranasal, intramuscular is what I would recommend. I would even go for an IV or an IO. And that's what the evidence-based guidelines would recommend. But that should be the basics of seizure management. If you're a BLS provider and all you have is your two hands and an OPA and a BVM, that's all you need. I see a lot of people who, especially even in the hospital, everyone gets really nervous with a seizure, and nobody's maintaining the airway at all. Everyone's they're looking for an IV. I'm like, stop doing that.
Trying to find a line in the anticube or in the foot. Get a nice 24 in the dorsal aspect of the foot.
Right, exactly. So now moving on from those basics. And obviously, the seizure patient likely does not need an advanced airway, right? They need basic BLS. They need a benzo. They may need a second benzo. In my protocols, we have ketamine for the refractory cases. But
Yay.
right. Oh, but almost never are we intubating a seizure patient.
Right.
But if you have to, you should do that. Next step, as far as the progression of airway management, would be the consideration. So we talked about OPA, we talked about NPAs, we talked about basic BVM, and now we're going to talk about the supraglottic airways. In my systems, the first thing we do when we get to a cardiac arrest for a pediatric or an adult patient, we do BVM breaths, followed by a supraglottic. We happen to use the iGel. Some people use the AirQ. Some people are using the King. Whatever your flavor. These airways are simple. They're easy to use. There are nuances, and you really have to teach to these nuances. I put out a few videos on this, but the supraglottic airway should be something that should be a BLS function, although in some states it's not.
We are in New Jersey, and it's not up here yet.
Right.
But so what? And I tend to agree with you. My first line has always been supraglottic and in cardiac arrest and IOs. Just real quick before we get out of here, what is your opinion on iGel or supraglottics rather versus intubation? And if you had one takeaway, you have to teach an EMT one thing, I guess about pediatric assessment, what would you tell them?
So for the first question, I definitely would say supraglottic first. And I would not go to intubation first. We all know that it's a tougher skill. It takes a lot more time off of the chest. So we've gone to the point where we just said, just put the supraglottic airway in, and no one lets us stop compression, because we look at all the different pauses and compressions and so forth. We don't want to see 2 or 3 large 20-second pauses because somebody was messing around in the airways.
Right.
So that's what I would say to that. There are issues with securing the pediatric iGel. Unfortunately, that company still hasn't done a good job in putting the hooks that the adult ones have. That's a problem, and I've told them that, and they know that. And as far as the last question, which was pediatric assessment, I think I would go back to what I said before, which is do the majority of your assessment before you come in and invade a child's space. Make sure that you get the confidence of the mother, meaning that I see a lot of people come in, don't even address the family. The kid is getting the cue off mom and dad, and not that you lose the kid. So if kids are crying around you all the time and you say, I can't get a good exam, that's probably a you thing rather than a them thing, right? So I think it's getting down to their level, staying calm, engaging the family. If the kid's not so sick, like make it personable, and then the kid look at you like, okay, mom likes this guy, I think I can like him too, and then they just relax.
Something that I've said for years, at least in my career, is the sound of crying children is like nails on a chalkboard to me. I was not built for OB or for the NICU or any of those places, but if I'm working on a patient, the sound of a crying child is it's music to my ears, because I know that their airway is open. They're probably responding appropriately to their environment. It answers more questions than it causes. But Dr. Peter Antevy, thank you so much. Pediatrician extraordinaire helping us out here. Thank you so much for your time and your knowledge, and we'll be right back.
Thanks, Ed.